A very big hello to all my dear students. So, welcome to the alphabetical series in your favorite channel, You and I with Dr. Ruchi Rai. So, which alphabet today? We'll talk about D. And of course, when we say D, how can we miss diabetic retinopathy? So, a very quick recap of diabetic retinopathy here. So, you know, when you say diabetic retinopathy and we are talking about the pathogenesis, what exactly is happening? What is the story? It starts with, we all know what is the pathology in a diabetic retinopathy. There is a microangiopathy. When there is a microangiopathy, because of the microangiopathy that is happening, which is mainly loss of pericytes, there is going to be, remember this, these are asked in the exam, that there is loss of pericytes and this is a microangiopathy. In diabetic retinopathy, what will happen? It will all lead to hypoxia. When there is a hypoxia, there will be increased capillary permeability. This is the basic pathogenesis for majority of the vascular lesions of the retina, which we are revising here. When there is increased capillary permeability, there is leakage. And when there is leakage, there is even more hypoxia. So, it is a vicious circle. This leakage in the retina will present as all types of exudates, hemorrhages and edema. So, I think you have the idea of what are the different edema. When I say it means edema at the macula, at the disc or elsewhere, anywhere in the retina. Similarly, we talk about hemorrhages which are superficial and deep. Flame shaped hemorrhages are superficial. I am not going to too much detail here because we will be focusing on diabetic retinopathy here. And deep hemorrhages is mainly, we are talking about dot and blot hemorrhages, deep hemorrhages, right? Okay. And exudates, of course, due to leakage, hard exudates are leaking lipids. What were soft exudates? They were axonal debris. Anyway, this leads to more hypoxia, and when the hypoxia increases, there is release of chemotactic factors, and this release of chemotactic factors will lead to neovascularization, and this neovascularization is finally depicted in the retina as NVD or NVE. Either it is at the disc or elsewhere, and this is leading to 3 blinding complications. Let me write it in red here. The 3 blinding complications will be, this neovascularization can bleed in the vitreous, leading to total vitreous hemorrhage. There can be tractional retinal detachment because all these neovascularization is also going to lead to your fibrous tissue growth, and that pulls the retina forward. And lastly, there can be neovascular glaucoma, right? Neovascular glaucoma. Okay. So, be very clear, if we are talking about neovascular glaucoma, why? Because any chemotactic factor which is in the retina will progress into anterior segment, lead to rubeosis iridis, leading to neovascular glaucoma. So, that becomes a different topic altogether. But anyway, this whole common pathogenesis in diabetic retinopathy or any vascular condition of the retina per se. Of course, this is only for DR, but any vascular pathology, it starts with this hypoxia and it leads to this. This is what is called, we can give one name, retinitis proliferans. So, this is the basic pathophysiology of any vascular disease in the retina, retinitis proliferans, isn't it? Okay. So, that was about DR, and then we talk about what are the different clinical features, what are the different stages, right. So, earlier the staging was background diabetic retinopathy, pre-proliferative or proliferative. We all know proliferative means neovascularization. Background diabetic retinopathy was, so when you say background, it is first sign batao. First sign of DR is microaneurysms. First feature of first sign is microaneurysms. Okay. Apart from that, all types of hemorrhages and exudates, this is your background diabetic retinopathy. Let me show it to you. So, this is what you have to know. When can you see these? These are what are hard exudates. These are the hard exudates, right? And these are the dot and blot hemorrhages. Dot and blot hemorrhages. This is the dot hemorrhage actually, right? So, when you are getting this along with microaneurysm, this is just background diabetic retinopathy. Then comes more hypoxia when there is more. I am first giving you this classification and then I am going to discuss the recent one as well. Then when the hypoxia increases, When it is going to increase, we are discussing the clinical features here. First is background diabetic retinopathy. It started with microaneurysm, then there are all types of hemorrhage like dot and blot and also exudates. Next we talk about is more hypoxia. Now what happens is, apart from all the features of BDR, we are getting some additional features which indicates, okay, now the hypoxia is more. This is just pre-proliferative stage. What are those indicative features? I am not writing. Let us quickly cover it up. Listen, you can write of course. More number of cotton wool spots. Why? Hypoxia is more, damage is more, therefore debris is more. So, increased number of cotton wool spots. Okay. Number 2, large blot hemorrhages. Okay? Large blot hemorrhages. These are venous infarcts. Number 3, what can happen is looping and beading. This is what is looping of veins. Okay? This is also a feature of pre-proliferative stage, looping of capillaries, and beading is something like this. Okay? And IRMA. What is IRMA? Lastly, these are all the features of pre-proliferative diabetic retinopathy. IRMA stands for intraretinal microvascular abnormalities. Then we come to proliferative, and when you talk about proliferative, we are talking about, apart from all these features, we get neovascularization. Let us label it here to get a more clear idea for you all. So, this is the NVD. Can you see this? This is the neovascularization at disc. Therefore, this is a proliferative diabetic retinopathy. What else we can see? This is your cotton wool spots, which is nothing but soft exudates, axonal debris. And hard exudates, these are the hard exudates. Okay, leaked lipids, these are hard exudates. These are all blot hemorrhages, large blot hemorrhage here, right? This is, I will just rub it, otherwise there is a confusion. So, this is your large blot hemorrhage, dot and blot, and this becomes your flame shaped hemorrhage. This is what is flame shaped hemorrhage. Okay? So, I hope this is clear now. So, this is your proliferative diabetic retinopathy. Okay? So, these are the clinical features. Now, before we go further, this is very important to revise, and that is ETDRS classification of diabetic retinopathy. What is that ETDRS classification? Almost similar to what you have just learned with me. Let us quickly revise. ETDRS classification says that you divide the diabetic retinopathy as non-proliferative and proliferative DR. This non-proliferative, the latest edition, it says very mild, and then comes your mild NPDR, then your moderate NPDR, severe NPDR, and also very severe NPDR. Okay? So, we have to quickly learn. Very mild means when there are only microaneurysms, this is very mild, right. Moderate means, mild means what? Mild is the same, all the features of BDR background, that is along with microaneurysms we have hemorrhages and exudates, this is your mild. So, all the features of background diabetic retinopathy is mild, easy. Then what is moderate? All the features of pre-proliferative diabetic retinopathy is moderate, easy. What is severe? We will learn 4:2:1 rule. This is again asked in the exam. We can make a Q here. So, what is 4:2:1 rule? It says that either if you divide the whole fundus into 4 quadrants, I am again focus here, all 4 quadrants, hemorrhages and microaneurysms in all 4 quadrants, or या ये मिले और नहीं तो looping and beading in 2 quadrants. If not this, then one is IRMA in any 1 quadrant. IRMA in 1 quadrant. Got it? So, this is what is 4:2:1 rule, which defines your severe NPDR. NPDR is non-proliferative diabetic retinopathy. And if you talk about very severe, it is more than one of these criteria is very severe. Means 4:2:1 ke 2 criteria together will be very severe NPDR. Proliferative, you know, is your neovascularization. This is enough. I remember one more question here, that microaneurysms is the earliest feature and in which layer? Please, we will answer nerve fiber layer. Okay, it is present where? It is in the nerve fiber layer. Talking about treatment part, we should know If it is non-proliferative without any macular edema, just wait and watch, glycemic control. But if it is, suppose, with macular edema, then our first line of treatment is intravitreal injection of anti-VEGF agent, and second line will become laser treatment, but we can repeat the injections at least thrice, okay, in an interval of few months. Then we talk about is, if it is proliferative, then our first line of treatment becomes laser therapy, that is pan-retinal photocoagulation, and secondly we can also add on to anti-VEGF intravitreal injections. Everybody knows anti-VEGF, vascular endothelial growth factor, is the main chemotactic factor for neovascularization, and anti-VEGF generally you should be very, very familiar with the names like bevacizumab, ranibizumab and so on. Okay? So that was about a very, very quick brief. One or two more questions here, that which is the most important factor for occurrence of diabetic retinopathy? You should answer it is the duration of diabetes. When I am talking about duration and it is a non-insulin dependent, I am talking about 20 to 25 years. Okay? And then second question is, what is the second most important factor? You will answer glycemic control. Third question is, when should you do the first fundus examination? Please note down, if it is a non-proliferate, if it is non-insulin dependent, that is type 1 diabetes, we do it after 5 years of diagnosis. In type 2 diabetes, we do it immediately, right? Why? Because type 2 is always diagnosed late. We do not know since when this patient is diabetic. That is why a first fundus examination should be done immediately, right? And then of course, I discussed with you the earliest sign of diabetic retinopathy is microaneurysms. So these are some important questions that has been asked in your exams, right? Okay, so revise diabetic retinopathy in detail. If you have any queries, you can DM me, okay, on Insta and so on, right? So thank you so much. Stay blessed and keep smiling.